a question on that.
Easy, should be all good.
Oh, sweet, thanks. Again, hard question. I got this wrong this morning when I read this. It is D. No, B, sorry. Oh, I wrote that in. B and D are the same thing. Oh, DEDS, yeah. Right. Yeah. High-risk patient, they need mechanical and Clexane, and you start that at least a few hours post-op to have a low risk of acute bleeding. All right. Why is that different? Weird. Okay, so post-op fever. This is probably the reason this lecture exists, is because everyone worries about post-op fever. I don't think it's terribly complicated, but it's a little more difficult in the way that you kind of have to think about what could be happening. So this slide is to kind of help you think about what could be happening. So I guess the point we're making is that a fever doesn't necessarily mean there's an infection. And so a fever is your immune system is pissed off at something. It's making, still working? Yeah. It's making all these prostaglandins, making all these cytokines. It's your immune system saying there's something wrong here. We need to bring the temperature up. So most common, or not most commonly, but most commonly we think of that as being an infectious process, but it can be due to cancer, it can be due to a systemic autoimmune disease, or in our case, surgery. It's a pretty big tissue injury. You're making big cuts, you're irritating things, your immune system gets pissed off because it needs to go in there and fix everything after. And so that's why you're getting a fever. Oh, I lost this recording on this one. Oh, he's gone. Okay, so this is what a lot of people use when they talk about post-op fever, the wind, water, walking wound. Think about weird things. On this day you can get this, on this day you can't get that. I personally don't find it's particularly helpful. So in the next slide, oh,
Is this still recording?
I have no idea.
Nice.
Well, there's a little recording button there.
Yeah, that's still good.
Cool. Maybe, yeah, so thanks, man. So as I said, I don't think that's particularly useful. This is how I like to think of it. It's a little busier, but it's essentially the same thing. So I'm just trying to catch up on the recording. So what I mean, not just me, but like myself and the people I've plagiarized this from textbooks, is the way you separate it is kind of, you think about early and you think about late. Some things can happen at both times. You can get infections early, you can still get infections late. Infections don't only happen on day 3 or whatever that other one thing is. But having that little kind of framework to think about, wind, water, wound, walking, it's still kind of helpful because it's catchy. Then I forget what the other one is, wonder about drugs, but I've changed, or not me, but in this table I've changed it to what have we done? So think about iatrogenic causes. The biggest one being in the first 24 hours, if someone has a fever, unless they're screaming at you that something's wrong, the answer is not going to be infection. It takes at least a day or two for an infection to set in. It just doesn't make sense for an infection to happen immediately, unless maybe it's a really kind of dirty, gross surgery, like a ruptured bowel or something where there's poo everywhere. But in general, in the first 24 hours, it's just going to be a physiological fever because of what we said. The immune system's pissed off, it needs to clean up your mess. And then other things are going to happen early. Reactions to blood products, that can cause a fever. If it's an organ transplant and your body's doesn't like it, or penicillins, a lot of people have allergies to them, you can get kind of a febrile reaction to those. And then other things that could happen show up. These are more infections. if you're putting things in like catheters, any foreign bodies, you need to worry about those things being a source for infection. So that'll typically happen, after a few days. And then atelectasis, again, that shows up in that other weird mnemonic, whatever you call it, as an early cause of postop fever. And then everyone always tells you atelectasis doesn't cause a fever, which is why I've crossed it off. Because the next slide, I think, is on atelectasis. There's nothing happening that can really cause a fever there. It's just, we'll talk about it in a second. But like that previous question, early on in the lungs, there can be an aspiration, or you can also get a pneumonia in the first few days. And then pneumonia can also happen again later on. There's no set time frame when infections are going to move in. UTIs, again, they can happen whenever. And with the wound, usually it's going to take a few days for an infection to set in, but it's not necessarily on day 4, whatever that one is. But then something like an abscess, that's going to take a little bit longer to set in. And then DVT and PE, those normally materialize after about 5 days or so. They tend to be considered a late complication, but I guess thinking physiologically, that shouldn't necessarily cause a fever either. But for the sake of being able to remember things and thinking about complications, it's nice to lump them all together. Oops. There we go. So this is what atelectasis is. When someone goes in for surgery, or they're a rib fracture, or for whatever reason they're not breathing well, they're not opening up their lungs really well, you kind of get some mucus plugging and the lungs don't quite open right. So that's essentially all it is. It's not like a pneumothorax. It's a little bit, it's just for whatever reason that person wasn't breathing right. It was a bit of a mucus plug, and you just can't get the good air entry in there. Again, I mentioned that earlier on. The thing that they may or may not include is atelectasis tends to clear with coughing, and the way to treat it is to encourage deep breathing, get them out of bed, physio, get them breathing again. But there's no kind of acute thing you can really fix with that other than make them breathe better. So I think here I've got a bunch of questions in a row now, so we can run through how all these things may or may not present. Again, I apologize, they're a bit wordy. Anyone has a guess? Yeah, so a lot of red herrings in there, but the first few words you see, it's 6 hours post-op, it's likely physiological. It's too early for any of those other infections or anything to set in. Anyone want to hazard a guess? Yeah, pneumonia. I think I meant to make it a little bit more kind of clear because, oh yeah, I did on my slide 38.5 and I added an extra day. I forgot to change the first slide. But it is a little bit tricky. She does have a fever and she's symptomatic. if in real life you go see this person, you probably wouldn't say, oh, he just got a bit of atelectasis and walk away. You'd probably take that fever a little bit serious, though. You'd probably be thinking pneumonia. So the thing that makes it kind of tricky in this is that having atelectasis or poor breathing is also kind of a risk factor for developing a pneumonia. But I think the thing in this case is the fever. It does have a fairly clear fever, and she is kind of actually symptomatic. So you'd probably be more thinking a pneumonia or something kind of actually happening. I don't want to take a stab. Yeah, there's a whole lot of red herrings in there, but at the end of the day, you pulled the catheter out. The pain is suprapubic, is lower abdomen. She's uncomfortable. She's in retention. I think. By the way, these questions are off a website called Past Medicine. I don't know if anyone uses it, but I think they tend to actually tease the concepts apart a lot better than the Monash questions. And the Monash questions are terrible, and they've all been changed anyway. So I don't see any point in using those ones. Yeah. So just not overthinking it. There's green stuff coming out. That's probably bile. It's day one. Too early to be an abscess. It's green. It's probably not bleeding. And she doesn't have like an acute abdomen to say that there's a perforated viscus. Yeah, wound infection. There's discharge coming from the wound and it's tender. And the time frame checks out. It's a few days later. I think it was 4 days. It just fits with a wound infection. Okay, and then these are some more specific ones. The first one, that is definitely C. So if anyone has any kind of airway compromise, you need to fix it right away. This is something that comes up on all exams. With thyroid surgery, it's a very vascular area. There's not a whole lot of room. So after you stitch that up, if there is a bit of a bleed, the only way for it to go is to push against the trachea. So that's obstructing that person's airway. And then before you do anything else, you need to snip those sutures and relieve the airway obstruction, even if it's going to make a mess and the surgeon might be mad. Next one. Yeah, it's E. So this is anatomy, Monash's favorite nerve, the recurrent laryngeal that runs right by the thyroid. If there's a problem with the vocal cords, you need to go and look at it. Oops, sorry. The last one, I just put it up. That one's a little bit trickier, but thyroid surgery as well. The parathyroid sit right on the back. So if it's a difficult surgery, you normally try and leave them there on a routine surgery, but if it's a bit trickier for whatever reason, I think this one, it's a redo. They might get damaged. And that person, symptoms of hypocalcemia, which is tingling on the lips, muscle problems. This person has an oculogyrate crisis, which is just the eye in spasm. And then the other one I didn't write down because I forgot the name, was the chopstick sign or whatever. You tap on the facial nerve and you get tingling, which is a sign of hypocalcemia. And the intrusive sign is a blood pressure cuff, the arm spasms because of hypocalcemia. And then I think this slide is just a summary of those, or just a couple fun facts about other things that can pop up. The different types of post-op bleeding. Primary is the first episode of bleeding, so that's intraoperatively. It'll never be the answer for a post-op question because that's just negligent. Someone shouldn't be leaving theater if they're still actively bleeding. But reactive is when under the surgery, the bleeding's controlled, but then as that person is waking up, the anesthetic's wearing off, their blood pressure comes back up, there might be a subtle bleed. Then that's different from secondary hemorrhage, which occurs kind of a week or down the track where there's an infection somewhere deep in the body or at the site or anywhere there's blood vessels are, and the infection kind of erodes away into one of those blood vessels. And then you'll get a frank, fresh bleed kind of a week or two later, which is how they normally frame it. Another thing that's come up in the past is if someone's got a respiratory depression post-surgery, they'll say respirate of 8 or something, how do you fix it? Which medication do you use? Yeah, naloxone. You can kind of infer that's probably from all the opioids you use to manage the pain, but then they might have pinpoint pupils as well. And then thyroid surgery, the things I just said. Airway obstruction, fix it. Hypocalcemia, how that can present, and the recurrent laryngeal nerve. Then the other one I've seen come up is if someone's getting a parotid tumor removed, the facial nerve runs right through the parotid, so that can cause a facial nerve injury. So this is kind of a summary of all of those things kind of lumped into one, which is a bit word heavy and not incredibly clear, but the issue with kind of a post-op assessment, there's, I don't know, they might not give you exactly a specific scenario on what you want to do. So it's good. The way I think about it is have in your mind a bit of a history of what's happened, kind of, and then let's say it was a thyroid surgery, you already have in your mind, okay, what have we done to them? What are the likely complications? And then your assessment, obviously with your vital signs, including urine output, which is an important one, kind of, we always say general inspection, and then you have to ask about all that equipment because like there's no actual IV lines and drain tubes and stuff for your sim patient. So you need to think in your mind, what are we putting into them? What reaction can they be having? If they're having penicillins or blood products, that could be causing the fever. And then again, what's coming out if there's pussy stuff coming out of a drain, if there's bile, you know, all the things can be bad and that could be causing the presentation. So just really trying to find any localizing symptom for the presentation, kind of working through systematically of what have we done to them, and then think of how infections or these other things would present at those sites.
What's your extra two vital signs?
Oh yeah, sorry. I put it on this slide up here. Oh, it's not that important. I think it was pain and GCS and pain. Yeah, see, I forgot about them. That's the problem with these revision lectures. Everyone comes up and tells you, this is what you need to know, but I think most of us like learned it this week. Oops, sorry. Question or a similar question has come up in the past. How do you give someone TPN? It's kind of a know it or you don't, but if it comes up, you'll be happy to put it on. Anybody? It should be by the book a central line. Yeah. Yeah. And then I guess the other key thing to know is enteral nutrition is the NG feeds or anything kind of going through the actual gut, whereas parenteral is through an IV line. And if it's in a like sometimes it's a PIC line, so it looks like an IV line, but it's actually a central line. And then I just copied this from a resources about the different ways you can feed people, but I think the only thing I've come up is TPN a central line. Next, let's talk about acute care. Before we move on, does anyone have any questions about the surgical, post-op, DVTs, fevers, all those lovely things we love to get tested on before we move on? Cool. All right, so acute care is similar, I guess, in a way to post-op surgical management. There aren't a lot of really specific things you can talk about, but I think one of the most important things I'll point out when we get to it, it's good just to kind of have an approach in your head of how you would approach an acute station or an emergency station and how that might differ from kind of a station where you're doing, you know, let's say an acute heart attack and management of that or kind of diagnosis of that versus how you would approach a chronic prevention of a heart attack station or the risk factors about heart attack. So I'm not actually going to really go into detail about any of these things, but I was just rattling off things that if any of those were to come up on a STEM, you should probably realize in your mind, they probably want me to do something relatively quickly about this. This person's probably in some sort of danger. So if it's an EMQ question, sometimes they say, what is the best investigation? It was one of these things I would prioritize something you can do quickly, efficiently by the bedside, rather than something like, I don't know, a blood test that might take a couple of days to come back, even though it might be the most diagnostic test. So if any of these kind of you see, have it in the back of your mind that they can be life-threatening and are emergencies. Then similar to what I was saying with the surgical station, you can't walk into a room and see someone is struggling to breathe or they're really sick. So you have to make up from the STEM outside, and pretty early on in that station, the first thing you need to decide is this person sick? Do I need to do something now? Or can we, you know, do things kind of the normal way? Because we can't kind of rely on what we're seeing in front of us because it just, the sim patients don't line up with the actual scenario a lot of the times. And then if it is going to be like a station where they want you to do something acute care, you need to also have in your mind, like, where am I? Am I at a rural hospital? So let's say for a heart attack, you might get a bonus point for saying, I need to call up like the transfer service. I need to get them to somewhere that can deal with this better than me, for example. Then all these things in caps, you need to, we're going to be a junior doctor in all of these stations. You need to realize this is above me. We need to activate the code. We need to get help. We need to get senior help. We need to do the doctor's ABCDs, which we'll go through, airway, breathing, circulation, blah, blah, blah. Get the vital signs, which is probably how you would actually realize it's an emergency station. IV access, fluids in, blood's out, and you want to prioritize the things that are actually going to make a difference quickly. So you're not going to order an MRI, even though it might be the best test for, I don't know what it would be. You'll do things like an ECG, a chest x-ray, things you can do pretty much immediately. Like VBGs are a good one to mention. So if it's going to be any kind of, then the rest from here on out is pretty much talking about basic life support and advanced life support, because it is a pretty common OSCE station. I included kind of probably more slides than I should, but I kind of broke down for each of these topics the things you should be doing and how you should be doing proper CPR, but obviously we're not going to do that today. It doesn't really work that well. But being able to, you know, have a run through of how you do CPR and do all the things properly in your head before OSCEs might be worthwhile, because it's a pretty common station. There's a few ABCs on this slide. The doctor's ABCs is like the basic life support community thing, but then the one most people use in the hospital when they say the ABCs is airway, breathing, circulation. And then disabilities, things like GCS, are they, you know, really sick, and exposure. We'll talk about later why that's important. So I'm not going to go too much detail into any of these things, but there's some pretty good resources online of how to manage the airway, which Goodell to use, how to properly use it. You measure it from the middle of the mouth to the corner of the jaw. In these stations in the past, they've paired kind of life support with airway management, or they paired life support CPR with like kind of ECG interpretation. So kind of, it's a good way to mix kind of practical things in with a bit of knowledge base. And then, you know, how to actually check for responsiveness, blah, blah. There's a good link there on the proper CPR technique. And for fun, there's a good one from The Office, which is hilarious. I guess the thing to remember with CPR, every time it comes up, we have to do it every year. And then I've had to do it like my CPR refresher outside. People always ask like, oh, is it true we don't do breathing anymore? It's not true, especially in the hospital sense. If you can, always use the Goodell airway and the bag valve mask. Otherwise, use the face shield. Yeah, it's probably looks at, if it's some sort of emergency station, I should have also said, like, you're not going to get bonus points for like running in and doing things immediately. They want you to actually run through all the steps. Like, it's a dummy in front of you. It's not actually someone actively dying. So you don't need to rush in and put your face right onto the dummy without putting that on. So I think this slide is probably fairly important. We break this down in the next few after this, especially on the right here. So the thing on the right is probably how CPR differs for us in the hospital versus how it differs to how we get taught at like community CPR. So the doctor's ABC, like that stops at breathing. Are they breathing? Do CPR. And then you just wait for someone else to come fix it. But a lot of the things could be very potentially testable, may or may not be from experience. So as we kind of go down that, we'll talk about when we use adrenaline, when we use amiodarone, but this flow chart is pretty good. So you're doing CPR, you do that for 2 minutes in cycles of 30 plus 2, 30 compressions, 2 breaths. You want to do that as uninterrupted as possible. And then if you do get a rhythm, what you do with it. So after this, we talk about the shockable rhythms and the not shockable rhythms and which kind of side of the flow chart we're going to. And then we go back up the top, and then what you do next, if that works or if that doesn't work. So how you kind of navigate this flow chart. So you guys have had cardiology yesterday? Cool, everyone hates ECGs, but it's probably good to recognize a few of them. Anyone yell out? Yeah, VT. So rate rhythm, it's a regular broad complex tachycardia. Yeah, sweet. You guys are on torsades. The thing I'm including that, torsades is also a type of VT. I guess a lot of times in your brain it goes torsades magnesium, but it's still kind of a type of VT, and to keep that in mind in terms of the life support flow chart where that fits in. This is a tricky one intentionally. Anyone want to hazard a shot in the dark? Yeah, I heard someone say SVT. Yeah, it's SVT, but I included because VT, the classical description of VT is a regular broad complex tachycardia, which is true, but the other way around isn't true. Every regular broad complex tachycardia isn't necessarily VT. So I think Will did cardio and probably talked about SVT, and it's a completely different management to how you would treat VT. All right, a little bit easier. What's this one? Yeah, sinus tachy. What's that one? What's rate and rhythm? It's just sinus, normal sinus, 75 beats per minute. So ECGs stress everyone out, OSCEs stress everyone out. But at the end of the day, you just have to think how we get from sinus tachy to sinus brady. All you just, you know, everyone going to these stations in real life, everyone takes their own pulse, they take a deep breath. All you have to do is listen to this guy, and everything will be fine. All right, let's talk about the real stuff. So on that flow chart, when you saw the rhythm, it goes one of two ways. It's either shockable or it's non-shockable. The shockable rhythms, ventricular fibrillation, that's very shockable. That person's in complete cardiac arrest. No matter what, they're going to be unconscious, they're going to be pulseless. That heart's not actually doing anything. It's just fibrillating. It's not pumping any blood around. So you just follow the advanced life support, which we went through. And then the kind of, if you follow that flow chart, you give a shock. If they don't respond, you go back to CPR for 2 minutes. You give another shock. If they don't respond, that's when you use adrenaline. So for any rhythm on the ALS under the shockable, it's the same thing. Every second go, you use adrenaline. And if it doesn't respond to adrenaline, that's when you use amiodarone. Is that clear as mud? And then the other shockable rhythm, that was VF. Next one is VT. So VT is a little bit trickier. VF is pretty cut and dry. That heart's not pumping any blood, so that person is going to be full cardiac arrest. But VT can be a couple of different things. There could actually be some cardiac output from a VT. So in the first scenario, similar to VF, that person's in VT, is not cutting it. They're unconscious, they're pulseless. You just do the same framework. You follow that ALS flow chart. Shock, assess rhythm, CPR. Adrenaline every second, and if it doesn't respond, amiodarone. Oops. So then the other way VT can present is unstable VT. So that's someone comes in like a heart attack. They've got chest pain, they're short of breath, their blood pressure is not steady. So this person's still awake. There's enough blood getting to the brain. There's still a cardiac output. It's still very much an emergency. They'll probably deteriorate to being unconscious or pulseless very quickly or into VF. But you do have a little bit more time to deal with that. So this kind of is in here because there were a few questions about kind of the different ways to approach these rhythms. So with someone who is conscious and they have some cardiac output, the first thing you do for that kind of VT is cardioversion. So cardioversion differs from defibrillation, not so much in how you're setting it up. You're still putting pads in their chest, you're hooking them up to the monitor. But with defibrillation, the machine doesn't sync it with their rhythm. So defibrillating, that person's already unconscious, they're in a bad way. You can't really make them any worse, you just shock them. Whereas if someone has an arrhythmia that's causing them lots of problems and you need to fix it pretty quickly, that's when you do cardioversion. So cardioversion is synced with their rhythm. And then I forget exactly which point it is, but there's a danger point in the cardiac cycle where you don't want to shock people because that can put them into complete asystole. So cardioversion times it right. If someone's got VT, they're still conscious, step one, cardioversion. And then as well, if it is torsades de pointe, which is a type of VT, and cardioversion, well, it's a bit tricky because the guidelines say cardioversion first, but a lot of times the questions say, you know, this person comes in, they've got risk factors of being malnourished, like anorexia, or they've got a bunch of medications, they're in torsades, which is the most appropriate. I don't think they would ever have cardioversion or magnesium, but they can both be used. And then now we're getting to like way down the chart. I don't think they would ask it, but then amiodarone again, if things don't respond, amiodarone. general for all these rhythms. Your plan A doesn't work, plan B doesn't work, try amiodarone. And then if they're completely stable, which I wouldn't think they would be, you can kind of do either one. So they can't really ask us on that because there's no guidelines. And then the other side of that flow chart, the non-shockable rhythms. So the first one there's nothing happening. That's just complete asystole. So asystole, there's just nothing happening. At least in VF, the heart's kind of like fluttering. Whereas in asystole, there's no electrical activity. There's no mechanical activity, just nothing's happening. So it's just lying there, not much happening. You can't shock that. There's nothing to shock and reset because there's just nothing. So that's where we go back to that same flow chart. CPR, you can't shock, give adrenaline right away. And then if that doesn't respond, go back to the top and keep cycling that. But the thing that's different in the non-shockable rhythms, it should be for all cardiac arrest, but specifically more for the non-shockable rhythms, the H's and T's, which are going to be on the next slide in more detail. Then, so in this scenario where someone's unconscious, they're pulseless, you get this trace back. What do you call it? Yeah. So that's exactly what it is. They don't have a pulse, but there's electrical activity. So that's pulseless electrical activity, which the electrical system in the heart is working fairly normally. So you can't shock it to reset it because there's nothing to fix because it's working pretty normally. But for whatever reason, that heart muscle is just not responding to those electrical signals. So then you need to go hunting for the H's and T's we'll talk about in a second, or what's wrong with that heart muscle to why it's not responding. So the lights are on, but nobody's home. What's happening here? So these are the H's and T's, which we got tested on last year, even though no one taught us about them. So here we are. So if you think about someone who's in a PEA arrest, they probably wouldn't just be a normal, healthy person, has a run of VT, and they just fall down. Normally it's someone who's pretty sick to begin with. So this is what the H's and T's are. The reversible causes of cardiac arrest. So something happened, and then now we need to fix it. So hypovolemia, how do we fix that? Yeah, just give them fluids. Hypoxia, how do we fix that? Give them oxygen. The electrolytes are off, how do we fix it? Fix it. Hypoglycemia, how do we fix that? Yeah, dextrose, because in this case, they'll be completely unconscious. Hypothermia, how do we fix it? Heat them up. If they're acidosis, we fix the problem that made them acidosis in the first place, usually septic or renal failure. So you need to go hunting for causes on why this is happening. Toxins, I've got a slide on that in a second. Cardiac tamponade, how do we fix that one? Yeah, you go Pulp Fiction on them, needle straight to the heart. Tension pneumothorax, how do we fix that one? Yeah, where? They love asking this. Yeah, second intercostal mid-collective line, which is different from a permanent chest tube, which is on the lateral side. Thrombosis, which is heart attack or PE, you just follow the guidelines, which hopefully someone talked about. And then trauma, you just fix it. Just call the surgeons, I don't know. I threw this slide on here. There's a hyperkalemia seems to be tested a little bit more than the other electrolytes because it's the physiology is a little bit interesting. It's really wordy, and the treatments are kind of interesting as well. And there can be some questions on what you do. So you need to decide how bad their hyperkalemia is. If you just see a blood, like a number, it's a little bit up, they're fine. You can kind of treat things a little bit more slowly. But if it's really high, like over 7, they've got ECG changes, they're symptomatic whatever way, then you need to do things quickly. So if there's any ECG changes, IV calcium gluconate is always going to be the first line for any of these questions. That doesn't actually fix the problem, but that buys you about 20 minutes. You give that to them, and that just kind of tells the heart to like, whoa, fell down here a minute. And then most of the causes for hyperkalemia are renal failure, acidosis switches, which ones go intracellular, which ones go extracellularly, so that drives serum up. all the medications that raise potassium, and then tissue injury, so like rhabdo or anything that's going to cause your cells to break open. And then the key medication to use to actually fix it, insulin puts things into the cell and fixes things, and then furosemide and dialysis actually get them out of the body. So it's a stepwise thing to buy some time, shift things back to where they're supposed to be, and then piss off the excess or drain it out. And then I think this is pretty much the last slide.